Good morning. My name is Lauren Kronisch, and I'm here to talk to you about the ketogenic diet, the evidence behind it for treating epilepsy, and the available evidence for using it to treat AHC seizures. And there's a little bit of research about other related events too. So first, just a little bit about me. I work at Texas Children's Hospital's ketogenic diet program. I've been a ketogenic dietitian for 9 years. And I also work with advanced keto therapies, which is how I came to present before you lovely people today. And we do remote telehealth ketogenic diet therapy. And we can talk a little bit more about programs versus private practice keto a little bit later. And just disclosures, I am a paid consultant for Functional Formularies, which is a formula company. So today, I hope by the end of the presentation, you understand the basics of the different forms of the ketogenic diet, the evidence for the ketogenic diet in treating intractable epilepsy, the evidence that's there for the ketogenic diet in treating AHC. Most of the focus is on epilepsy and AHC, but there's some other information in those studies too. And the basics of what is the first year on the ketogenic diet. So I'm going to talk in great detail about the particulars of keto, but first I thought I'd share the evidence, but you're not going to understand some of the terminology if I don't tell you first, basically, what's keto. I'm sure most of you have heard keto before. Has anyone in this room ever been on keto or had a child on keto? Okay, cool. Like to hear more about that later. So it's a high fat, low carb, adequate protein diet when it's done right. It's on the internet. It's been a fad diet for a while and usually touted as weight loss in adults. That's not at all how we do it when we're doing it as a medical treatment. Therapies, like we call, kind of like a medicine, but it's a diet. And so I just wanted to point that out, and you'll see more when it gets into how detailed the different diet particulars are. But for now, even though some of the things about it being a fad diet are frustrating for us therapy people, it has led to a great number of food options that just weren't there before and can really help it be successful in pediatrics or in picky eating or in certain things. It's not right for everybody, but it has helped a lot. So some of these pictures of foods at the bottom are some of my favorites. We got our folio cheese wraps, ratio keto yogurt, cacao butter, which is the basis in a lot of truffles, but it can be used in keto too. Chalk Zero, really tasty, low carb chocolate, and fat snacks cookies. So in ketogenic diet programs, which are hosted in hospitals, usually to treat epilepsy and other specific genetic disorders, there's specific protocol and every program is different. And we can talk more about that too. Sometimes it's started urgently in the ICU when someone's experiencing status epilepticus. That's a little bit different than the outpatient starts, but it's when, you're throwing the kitchen sink at it to see what would help. Sometimes it's an elective admission to the hospital to start, but sometimes it's done outpatient, sometimes it's done remote telehealth. So just a little bit of history about where did keto come from, not just from the internet. There's references to the ketogenic diet all the way back in biblical times related to fasting and improvements in seizures with fasting, all the way from Hippocrates in 400 BC. And then in the 1900s in France and the US, there was some use of fasting for treating seizures. In the 1920s, it was being used to treat seizures at the Mayo Clinic in the US, but because then in the 1930s, a lot of anti-seizure meds came out onto the market, there was more of a movement to using medications for treating epilepsy. In 1971, a doctor called Huttenlocher developed the ketogenic diet. Sorry, I have to remember to move my cues and the slides at the same time, so apologize. He developed the MCT oil diet, which I'll explain more in a minute. In 1972, Johns Hopkins in Baltimore started their official program under Dr. Livingston. But again, because there were really amazing medications coming out, also side effects, but amazing medical science medications, the diet wasn't getting much of a focus until Jim Abraham came around, who started the Charlie Foundation, which is a great patient advocacy organization and resource for you guys to check out if you're interested. Some basic information on the ketogenic diet. And his son, Charlie, had epilepsy, and they were looking for something that would help his seizures because the medications weren't working entirely to have good seizure control. And they came upon the ketogenic diet. It helped him become seizure-free. And so then they started the Charlie Foundation in the 90s, and then they made a movie about it with Meryl Streep in 1997. And all this really helped get the ketogenic diet a lot of attention. And they raised a lot of money for good studies on the ketogenic diet safety and efficacy. And that really helped lead the diet to become a popular option and have a lot more research done on it, which has led us to where we are today. The first randomized controlled trial was done in 2008. And there's an international meeting on it now every couple of years all over the world. Practitioners come together. There's one coming up in San Diego in September. And there's also international consensus statements with providers from all over the world about how to best do the diet, what's safe and in what conditions, and how and when to improve it, when to stop, adverse effects, and all of these things. Okay, so what are indications and contraindications for using the ketogenic diet? It's very strongly indicated for GLUT1 deficiency and pyruvate dehydrogenase deficiency. Specific etiologies for epilepsy, including Deuce syndrome, tuberous sclerosis, Rett syndrome, Dravet, infantile spasms, Lennox-Gastaut, oh, I went too fast, and other refractory epilepsies, which is what AHC would fall into. Contraindications include carnitine deficiency, CPT1 or 2 deficiency, say some of these 10 times fast, I dare you. Fatty acid oxidation disorders, pyruvate carboxylase deficiency, porphyria, if you're unable to maintain adequate nutrition or non-compliance with treatments. And this is where a good team really comes in key. But there are more recent uses for the ketogenic diet, some of which have some good evidence behind them, some of which don't, but people are still trying them. So these include migraines, mental health disorders, cancer, autism, Prader-Willi syndrome, multiple sclerosis, Parkinson's, diabetes, PCOS, metabolic syndrome, ALS, Alzheimer's, and traumatic brain injury. Really are just tipping the head of what could this diet help with, but it's also really important to make sure that it's done so that you have a lower chance for some of the adverse effects that can happen. Okay, so this is evidence for the ketogenic diet in intractable epilepsy, which most of the best evidence is for that. There are some great papers for cancer and some other syndromes too, and there are some on AHC as well that we're going to talk about, but really extensive research at this point done about the ketogenic diet, proving that it can be safe and effective treatment for some people in treating intractable epilepsy. So by 2019, there were 4 randomized controlled trials, which is like the gold standard in research, with moderate to strong evidence for the efficacy of the ketogenic diet compared to medications or a control, which have led to it as known to be a valid scientifically based treatment. There have been more RCTs done since 2019. One recent one in 2020, the Journal of American Medical Association Pediatrics, they did a study, it was a randomized controlled trial, comparing the efficacy of the low glycemic index diet, which is one type of ketogenic diet. I know all this lingo gets a little bit confusing, but I will break it down and be able to answer plenty of questions. Comparing that to the more traditional ketogenic diet with 170 children ranging from infancy to adolescence in India, and it proved that it can be a good balance of lowering the chance for adverse risks that come with the strictest form of the ketogenic diet and still get some good seizure control. It's also now known to be the best second or third line treatment in treating infantile spasms, another type of seizure. But it's really important to do it safely. And so this 2018 International Consensus Guideline recommends an experienced professional manages the ketogenic diet. You're more likely to fail without some guidance and to experience some of the negative side effects that can happen. So this is a slide just showing, comparing efficacy of multiple seizure medications with the ketogenic diet. So compared to medicines, the diet has a pretty good chance of being successful. If at least half of the kids who have intractable epilepsy will have a 50% or better chance of a 50% or better improvement in their seizures, which is pretty good odds compared to a seizure medication. Most of the kids we have, you're not going to try the diet alone for most people, but there are some people under the proper guidance of their physician. If the diet is successful in improving their seizures, then they might be able to wean some of their medications. Also, a side effect that's not really well discussed in research, but I see it in a lot of the kids that I treat with the ketogenic diet, and adults too, is that people seem to have more alertness on the diet, and we don't know if it's its own thing with something that the ketogenic diet's doing to the brain, or if it's counteracting some of the side effects of the medications. But because of that change, there are some people who can develop or be able to do things that they couldn't do before, pay more attention, track, depending on the person. Okay, so evidence for treating AHC with keto. It's limited at this point to case reports and case series. I found a total of 7 published papers, but that's where we start, right? So I wanted to go through these in more detail because I knew you'd be most interested in them. So one case series that was really about studying the genetics of AHC, not about keto, done in 2014 by Epilepsy et al. In Spain and Greece. Of the 10 kids that they studied, 3 of them were on keto. They were all on flunarizine without much improvement. So of those 3 who were on keto, one was a 16-year-old who at age 3, they were on keto for 1 year, and they found significant improvements in school performance, mood, and socializing. And also their dystonia attacks went from once a week to once every 3 weeks. Patients 2 and 3, one of them was a 37-year-old male and another was a 4-year-old female. Their hemiplegic attacks stopped and they had improved mood, attention, motor skills, and cognitive function. There was a case report done in Japan by Shirinzi et al. In 2018 of just one 20-month-old male patient who was followed for 2 years and 7 months. And they were on a 3-to-1 ketogenic diet.
Could you try again?
Oh, that's Siri. Sorry, guys.
I'm listening.
Nope, don't listen. I don't need you to do that. Okay, I think it stopped. All right. She was on a 3-to-1 ketogenic diet and diagnosed with AHC between 1 to 2 years of age, and also diagnosed with epileptic encephalopathy in infancy. And he was able to have seizure freedom after 16 months on the diet at first, and then had 1 seizure every 2 to 3 months, and an improvement that was noticeable in the EEG. Also, the non-epileptic paroxysmal episodes significantly improved. They were able to lower seizure meds, and they had improved neurocognition and motor skills, but still a mild speech delay. Okay, moving on to a 2015 case report by Alate and Campos of a 10-year-old female who had her first hemiplegic event at 12 months of age, and dystonia starting at 5 months, and microcephaly. She had partial improvement before keto with flunarizine, but further improved with a 4-to-1 ketogenic diet, which is the strictest one you would normally start with, starting at 4 years of age, and had a 90% improvement in paroxysmal events on the ketogenic diet. And her hemiplegic events spaced out to once a month to 1 every 6 months. She also had improvements in motor function and was able to go from being wheelchair dependent to walking independently. Another case report in 2015 of a 13-and-a-half-year-old with familial AHC by Ruberge and et al. Started with a modified Atkins diet, which is one of the more liberal forms of the ketogenic diet. Still very different from a normal diet, but you'll see what I mean in a minute when we get into the diet details. Had a 10-gram net carb restriction per day with increased fat, which is what the modified Atkins diet is when it's done for therapeutic purposes anyways. After 10 months on the diet, liberalized to 20 grams of net carbs per day, which is still like less than one serving of Cheerios, and had 100% resolved dystonic and hemiplegic events, which was ongoing at 15 months on the diet. But one limitation of this case report was that the 3 other members in the family with AHC had resolution of all of their symptoms with medications. Okay, so what are the different types of keto you just heard me talk about? There's a traditional classical ketogenic diet, which is the strictest form of the ketogenic diet. There's the modified ketogenic diet, the modified Atkins diet, the MCT oil diet, and the low glycemic index diet treatment. So this kind of breaks them down compared to each other, just the different forms of increased amounts of fat. They're all higher fat than a traditional diet, but they do vary a little bit in their particulars. But I think it's going to be, this is more just for you, for reference for you. I think it's going to be easier to understand once I walk you through it all. Okay, so a classical traditional ketogenic diet, the strictest form of the ketogenic diet is everything is weighed. Well, a lot of these, when you first start, everything is weighed, but some of it can loosen up over time. And I know this is kind of a sad picture of a meal. They're not all this sparse looking, but what I will say is that it's striking at first because there's more calories per gram of fat. Your meals do look smaller even when they have the same amount of calories. But especially with children, the reason why it's important to be under the care of an experienced professional is because things have to get adjusted all the time for appetite and all of that. But this meal is like an egg wrap with some sausage in it, some cheese and strawberries, and a little bit of heavy cream on the side. So the strictest form of the ketogenic diet is 90% fat, just enough protein to meet the DRI, which is usually only possible if someone's eating enough calories that you could make that ratio work and still get enough grams of protein, which is really important to meet for growing children because you need it to be able to grow and build your cells and all of these things. So you get enough protein, a little bit of fruit and veggies, and a lot of fat. The modified ketogenic diet has quite a range in it. And so I feel like it's easier to understand when I talk about the modified Atkins diet. Not everything is weighed, just carbs are, but a lower modified ketogenic diet, 1.75 to 1. So what these numbers mean, I try not to get too deep into it because some people love math, some don't. But the first number denotes the number of grams of fat in the amount of food per gram for every gram of protein or carb. So like a 4-to-1 ketogenic diet is for every 4 grams of fat, there's 1 gram of carb or protein. So you have to have that ratio right in the total amount of calories. Okay, so modified Atkins diet, one of the most liberal forms of the ketogenic diet, you just count carbs, but you need to add enough fat too. So every time you're eating, you still need to eat a decent amount of fat, but you can eat as much protein as you were eating before. And it ranges from usually 10 to 20 grams of net carbs per day. And so it works out to about 64% of your calories in fat, 30% in protein, which is pretty comparable to the traditional American diet, and 6% of carbs. Okay, the MCT oil diet, I bet most of you have heard of MCT oil in one form or another. And MCT oil can be very effective at helping ketosis because it skips a step in fat metabolism that no other fat can really. So it's more efficiently metabolized compared to other types of fat. And so in the MCT oil diet, you use a lot of fat and a lot of MCT oil. And so only some people can tolerate this type of diet. It's weaned up slowly because there can be some side effects from using a lot of MCT oil, and what that dose is depends on some people, but it can cause loose stools, which is welcome for maybe some people who are having constipation. It might not give them loose stools. It might just help their constipation. There's some people who aren't on any form of the ketogenic diet and they take MCT oil just to help their constipation. But in this case, it also gives you the ability to have a lot more carbs than most of the other forms of the ketogenic diet because you're using so much fat. So it's approximately a 2-to-1 ratio, but You're using a lot of this odorless, tasteless MCT oil, either mixing it with smoothies, into salad dressings, freezing it into fat bombs. And this is also helpful for people who are plant-based eaters because their forms of protein just have more grams of carbs in it than animal protein eaters. Okay, the low glycemic index treatment diet is defined a little bit differently depending on the program or practitioner you're talking to. So I'm sure a lot of you have heard of the low glycemic index. It's this index of how much your blood sugar will get spiked by an amount of a particular food compared to like a piece of white bread is the highest, for example. So that's the underlying rationale for it. So in some programs, using a low glycemic index diet, you'll just use that scale and only eat below the lower end, like the lower 50% of what would increase your blood sugar. But in other programs, they're going to give you a specific macronutrient pattern to eat for each meal and snack. So like 10 grams of protein, 16 grams of carbs, and 40 grams of fat is an example of one of my clients' breakfasts, for example. This also enables you to have some more carbs, which can be helpful for some people to make it be a successful longer term option, and can be helpful for plant eaters also. Okay, so after all these numbers and descriptions, I just thought I'd show you like what are some meals besides that first one. What do they look like under different forms that might help illustrate and internalize what do these different types of diets mean? So for example, modified Atkins diet, this is a modified Atkins diet. Crab cakes, it doesn't use flour breading, it uses something else and a bunch of mayo, a little bit of greens. The middle one, those macadamia nut donut holes are really delicious. They're made by one of the formula companies. They also make medical foods that come freezer ready, just shove them in the freezer. They are expensive, but they're really helpful for some people who can get them, or maybe to keep them as a backup, like if grandma is providing dinner, for example. So this meal is a 2.5 to 1 ketogenic diet. So it's a modified keto diet. And this might be a breakfast of macadamia donut holes, heavy liquid cream, and milkadamia nut milk mixed together. And this to the right is an avocado ice pop. It's pureed avocado with some heavy cream in it and some lime juice and a little bit of an artificial sweetener. Okay, so some other questions that I typically get from people learning about the ketogenic diet. What if my child gets fed through a tube? What do we do? So there is a wide range of complete nutritional foods by companies. And then, I even have some clients who make their own whole foods blend-rise ketogenic diet that they feed through a tube. So I just wanted to share what some of them are. So there's Keto. They make a bunch of powdered and liquid formulas that some of them are ready to feed, and the powdered ones you mix up kind of like baby formula. Keto V is another maker of a bunch of ketogenic diet formulas. They also make modulars like MCT oil with an emulsifier in it. That liquid into the right is an example of that, which means that if you mix it into something like tea or a beverage, the oil won't separate out over time. It'll be evenly distributed, which is nice for kids who might have textual sensitivities. We also use modulars like protein powders to make sure we're meeting protein needs. RCF is a soy-based baby formula, but we end up using it in children who are not babies too, if that's what they'll tolerate. And then functional formulas is a whole foods keto-based formula. Okay, what if my child has dysphagia? So we can do the ketogenic diet if your child has dysphagia, if they'll tolerate some of the specialty things that we have to do. So we just have to switch to a keto-friendly thickener. So one of those is xanthan gum, which is not recommended in children under 2 years of age, but we can also use Simply Thick, and that is a medical nutritional food. I will say that if you're having a lot of thickened fluids, you can have some trouble getting to optimal ketosis, but some people get there just fine. And if your child eats purees, then it's just a matter of adding something special. or something modified. So for example, this is an example of smooth pureed sweet potato, and you mix in a little bit of coconut oil, or smooth pureed avocado if they eat soft mince, and you can mix in some minced beef. Okay, so how do you start keto if you're interested? Under the care of either a ketogenic diet program or a trained professional, which you can find from the Charlie Foundation. They have a great resources page, which will tell you by geographical location, where are the programs and where are the individual practitioners. Some programs require you to have an elective inpatient admission to start the ketogenic diet, and some do all of their starts on an outpatient basis. So it really varies by program. And I will say, if you want to maximize usage of your insurance and you're interested in the keto diet and you have intractable epilepsy, then pursuing the ketogenic diet through a program would be the best option for you if you have one that you can get to or is close enough to where you live. But some people don't, and that's where the private practice people can really come in handy. There are some potential side effects of the ketogenic diet, which I think are important to go over. And some of these things I'm telling you, there are more things like we would go over in initial consultation, but I'm thinking, what does someone who doesn't know about keto want to know? I would think the good and the bad. So there are some potential negative side effects of the ketogenic diet. Most of these can be mitigated by, and I'll walk through what, but some of them cannot. So constipation, I would say like 80–90% of people, when they first start keto, they either get constipation, or if they had constipation, it gets worse. But the good news is it can be managed by adding on things like flaxseed oil, Miralax, increasing the dose of Miralax. I've been able to use prune juice or prune purees effectively in some people. Another is kidney stones. So you're at a double increased risk for this if you're on a medication that already puts you at increased risk for kidney stones, like Topamax, for example, is one of them. So it doesn't mean you can't do the ketogenic diet, but it does mean that we would start you on a buffer, like potassium bicarbonate, for example, to help lower the risk. And we would carefully monitor you and probably get labs a little bit more often to make sure that we were checking in to make sure that that's not going on. Hyperlipidemia, very common the first couple of months on keto, and then it seems to normalize around 3 to 6 months on a ketogenic diet. We don't know why that happens, but this is well described in research. So we check at baseline. This is included in the baseline labs. If you have a baseline hyperlipidemia, then we would usually want to first find out, probably send you to preventive cardiology, make sure it's not a congenital hyperlipidemia. And if there is, ask that cardiologist for clearance and make sure the ketogenic diet's a safe option for your child. Pancreatitis, and this is more like if someone, I've only seen this in the case of a patient in my keto program at the hospital, and they were non-compliant. They weren't responding to our phone calls for follow-up visits. And unfortunately, they came into the ER with pancreatitis, and we had to stop the diet. Prolonged QT interval, this has been described in some research, and at baseline, we get an EKG to make sure that your heart rhythm is normal at its baseline. If it's not, that may be another reason why we would get cardiology involved to make sure the diet was a safe option, but this can happen over time on the diet. So it's important. This is another example of why it's important to have follow-up and just make sure the diet continues to be a safe option. Okay, so if you are interested, I strongly recommend that you do this only under the care of a trained professional or a ketogenic diet program, which you can find from the Charlie Foundation. Like I said, some programs require an inpatient stay to start, just to monitor and lower the chance or help mitigate them if you have some of the things that can happen when you start on the ketogenic diet, like low blood sugar or some acidosis in your blood. It lets people tweak the diet to make sure that you're nice and stable on it before you go home. But for programs that do start the ketogenic diet outpatient, they will start you much slower and over a longer period of time, which seems to lower the chance of some of those adverse effects that you might get from an inpatient stay. So just an example of how referring to a program would go for the ketogenic diet. For example, in my program, you have to be referred by your epilepsy doctor. In other words, they have to agree that it's an appropriate treatment option for your child. And then we have a whole bevy of labs and EKG done at the baseline to help make sure that you don't have any of those contraindications like carnitine deficiency or any fat metabolism issues, which would be one of those strong contraindications for the diet. In our particular program, it's a 3 to 5 inpatient stay for modified and classical diets, but it's an outpatient if it's an Atkins diet education or MCT oil diet or low glycemic index treatment diet. We have had a couple that we did start outpatient on a low and slow model, mostly because we had children with respiratory needs who required a transitional ICU stay. And we had this big backup from COVID of elective admissions. And so we did start a couple, but on a stricter regimen of getting more updated labs with that low and slow model that some programs use exclusively in their programs to start the diet. Follow-up is typically well, first you have a 1 month and then it's every 3 months for the first year on the diet. And then it's to the team's discretion. So in our program, that 1 month visit is with the dietitian only. And if any tweaks need to be made to the diet with some labs before you come in, then we tweak it in collaboration with the keto epilepsy doctor. And then all those visits after that are with the keto dietitian and a keto epilepsy doctor together in the visit. Okay, so in conclusion, the ketogenic diet is a safe and effective treatment for people with seizures when you're under the care of an experienced team, and it has a better chance of success compared to any seizure medication, but it's more often done as an adjuvant treatment. Initial results look promising for the ketogenic diet in treating some paroxysmal events possibly, and definitely seizures and ACH, but we need more research with better study designs to further investigate the impacts and outcomes of the ketogenic diet in AHC. If you would like some more general resources to explore a little bit more, the Charlie Foundation is a great resource. They have testimonials from families who are or who have been on the diet. That's where you can find a program, a private practitioner, and also this book by Kostov et al., which is out of the Johns Hopkins team. It's a great book for getting some more detail about what are these diets and the history and some of the research in a little bit more detail than I've explained. And Advanced Keto Therapies is the remote telehealth keto practice that I work in with Denise Potter, who she also previously was in a keto program at Mott Children's Hospital in Ann Arbor. And now she's got a great team of, oh gosh, I think it's 14 of us who mostly work in hospital programs during the day, but we also do some remote telehealth keto to help provide it to people who might not live somewhere where it'd be, they have access to a program that they could really go to. So thank you for your time. I know it's the last day and it's Sunday morning. Thanks for having me here. It's really nice to get to know all of you folks more. I knew about AHC. We have some kids in our movement disorders clinic, and we have a small handful in our keto program, but I learned a lot more coming here and attending sessions, and you have a really nice community. So thanks for having me.
Okay, go ahead. Do we have any scientific research on why it works? Like, why does keto work for the epilepsy and not other diets?
Yes, they're really trying to figure that out. We don't 100% have an answer, but some of the current research suggests it has something to do with GABA or mTOR, but we haven't completely elucidated the exact mechanism and proven it. And then there's some interesting research in cancer where in certain cases, if you can tolerate it, and it's done again under an experienced team, it can help with tumor growth. There's some research, it's really just beginning, but there's some thought in psych disorders that it can have an anti-inflammatory response, but really they're just kind of beginning to explore all these things. There's not the kind of research that there is behind it for treating epilepsy.
Getting your exercise. You already worked out too. Hi, thank you so much for being here. That was a great talk. We have a 15-and-a-half-year-old AHC child, Asher, and we actually did keto, maybe modified keto a couple of years ago. And he has, most of the time he has fairly mild episodes. We're not sure if he's having seizures or not. He is starting to have like spasmodic episodes, but they last about a minute to 90 seconds. So we're not sure if he's having seizures or not. His EEGs are great. Anyway, a couple of years ago, we had great success with the modified ketogenic diet that we did. We didn't do it under consult of a doctor or an inpatient facility. We did notice a decrease in episodes. We did notice he was much more alert and had much more energy, went further throughout the day without needing to rest, things of that nature. It was more difficult for us, for him emotionally, because it was just one more thing that he was different for. So it was just tough. And behaviorally, it was, he was 13, puberty hit, and he just was arguing a lot about it, basically, for something to argue about. Anyway, I guess my question is this. So he's 15-and-a-half. Would you still recommend that if we wanted to do something like that we would do an inpatient program, or is it something that is he old enough now and has more of a mild case? Do you think we could do it on our own? That's the question. After all that, sorry.
I would say for most people who are eating a regular traditional diet, which he has been now, if you came to our hospital program, we'll probably say try modified Atkins diet because it's a little bit more liberalized. But I would say there's an argument to be made for a lower ratio ketogenic diet, because sometimes that the loosey-goosiness that can be in modified Atkins diet sometimes doesn't lead to as good a results with modified Atkins. But for some people, you see the kind of optimal results you would expect in a really strict ketogenic diet with modified Atkins, which I think comes down to genetic differences that we just don't have enough research on to really be able to pinpoint. But I would still say go through a trained professional and talk to your neurologist about it, see what they think, whether, decide to do it or not. I mean, there are even options where if you did it through a private practice person, it doesn't have to be like you're seeing them every week. So it kind of just depends on the case, but I still think it's good to get buy-in from the team and get all these different practitioners collaborating with each other and get their input. Yeah.
Thank you for your presentation. I understand that most of the D801N kids have an issue with the QT interval, so they must not take certain medications because it affects them. Given that one of the side effects of the keto diet is a prolonged QT interval, what is the interaction between this diet and D801N patients? Is it still recommended for those patients?
So I will say that the prolonged QT interval, it's not like a very common side effect, but it is important to monitor and come to follow up so that like we have a huge set of annual labs that we get redone, which minus the genetic labs are very similar to the ones that we get when we're considering somebody for the ketogenic diet to make sure that it's a safe option. So that includes an updated EKG to check. So it's not something that I would be concerned about unless we see a baseline, but that's where the monitoring part is important because things can change over time. But the other part of your question, I honestly am not knowledgeable enough to answer with regards to that specific genetic mutation and its effect on, the heart, and then add a ketogenic diet to it. I honestly don't know the answer to that. So
thank you very much for that excellent review. My experience with ketogenic diet in epilepsy, we've had patients who come under 100% control after being intractable. It's the most amazing treatment. It's ironic that this was biblical. It's really a biblical change. And so it's for epilepsy, it's clearly proven, especially with infantile spasms, but we cannot minimize the side effects. I've also seen children with very severe side effects, and don't tolerate the diet and don't gain weight and have intractable vomiting. And so these seem to be limits for certain families. I think one of the pathophysiology is beta hydroxybutyrate, our increase, which is thought to be a natural anticonvulsant, anti-inflammatory in the brain. And at least my last look at the research from several years ago, it seemed that was thought to be one of the beneficial effects to control seizures. As far as AHC, I think that is still open. We have these 7 publications, and people tend to publish positive results. We don't know about how many others this was tried, and there's a tendency not to publish positive results. You don't want to show your failures. So I think it still remains open how beneficial this is for paroxysmal non-epileptic symptomology. I have almost at every meeting I discuss with families who had tried the ketogenic diet, and I think it's a mixed response.
Thank you for your input. Yeah, we have some people who get admitted to start the diet and they don't tolerate it. That doesn't happen very often, but it does happen once in a while. They get reflux that can't be well controlled with medication. Some of them vomit, and we'll try, everything we can, from switching formulas to extending feeding times, eating slower, eating smaller meals more often, but some people just don't tolerate it. A lot of people do. It's also tougher, I think, for picky eaters. We can say and offer whatever we want, but if a child doesn't eat something, then that's a problem. And so some of those are the reasons why someone needs to be monitored, and you need to work with an experienced dietitian so that if we can tweak something, we do. But if your child can't eat enough to sustain growth, then that's not going to be a good option. But that's where going to a trained professional in the beginning will help you figure that out before you even try, because we don't want we want a child to grow and develop as best they can. There is some research about the ketogenic diet causing growth problems. It seems to be less of a chance for that with less strict forms of the ketogenic diet. And so these days we're trying to try the more liberal or lower ratio options first, everywhere except maybe in the case of an urgent ICU start, so that if we can see good results on one of these more liberal or less restrictive options, no question, they're all still restrictive compared to a traditional American diet. But then we're mitigating that risk a little bit. But it is something that needs to be monitored. And sometimes it's a pros cons thing if the diet is effective for somebody with hard to treat seizures. Thank you. And if anybody has any other questions later, feel free to email me. My email's on this slide.